vessels, we usually treat that with injections. And Mr. Belgrave mentioned injection of steroid. That's one of the treatments that we have available to treat the leakage from the blood vessels. But there are other drugs that can be used as well.
About people who may also be affected by glaucoma, which is supposed to be more of something you inherit. So how does that complicate the situation if you're diabetic, you have glaucoma, and then this diabetic retinopathy is threatening?
Well, so glaucoma secondary to diabetic eye disease is slightly different. What happens is you have these abnormal blood vessels growing at the front of the eye instead of the back of the eye. And because of their unusual position, they block the drainage of fluid from the front of the eye. And it causes the pressure to build up and go up. And this is a type of glaucoma that can occur. So we usually treat that again with injections of this drug, followed by laser at the back of the eye to try and prevent the blood vessels from growing back. But there are usually two independent diseases. Open angle glaucoma, which is the most common type of glaucoma in Barbados, is usually separate from diabetic retinopathy. But because diabetes tends to occur in, not always, but in an older age category, especially the stage where you're reaching complications, then you can have glaucoma as well as diabetic eye disease concurrently.
So, are there different types of diabetic retinopathy?
Yes, so diabetic retinopathy is graded. So when a patient is first diagnosed, you can look at the back of the eye and you can say there's no clinical sign of diabetic retinopathy. And then after that, you have the mild, moderate, severe stage of diabetic retinopathy. And in each increasing stage, you're seeing more evidence of leakage, where you see these kind of yellow exudates at the back of the eye, or you can see more evidence of bleeding at the back of the eye. And then towards the more advanced stage of the disease, where you have these abnormal blood vessels growing at the back of the eye on the retina, or you can have something called macular edema, which is simply leakage of protein into the center of the eye. And macular edema actually is the most common cause, or one of the most common causes of blindness in the working age population. So that's something that we need to try and address and pick up as soon as possible to treat, because there are very effective treatments available.
I'm curious about how bad the situation is in Barbados, from your observations.
Yeah, any stats?
So worldwide, the prevalence of disease is around 8%, and in Barbados, we're running around 13%. The statistics vary, but between 13 and 18%, that's our estimated prevalence of diabetes. And then from that, you can say 30% of those people will have some form of diabetic retinopathy. Again, you can change that slightly and say after 10 years, 20% of people will have a form of diabetic retinopathy. And after 30 years, 90% of people will have diabetic retinopathy. And of that, around 7% will have sight-threatening diabetic eye disease. So it's quite a significant.
Sorry, it's significant.
Proportion of.
Yes, but we're going to come next to hear from the psychiatrist who is with us. But just before we go there, one more question relates to this issue here. We've been told you control your blood sugars to avoid diabetic retinopathy. But can you get it even though your blood sugars are well controlled?
You can, but you're likely to have either most likely the mild form of diabetic retinopathy if you have very well controlled diabetes. You're unlikely to advance to the moderate, severe, and even the advanced stage of diabetic eye disease if you have well-controlled diabetes. But unfortunately, there are other factors as well. So blood pressure control, that also makes a big difference towards development of diabetic eye changes.
We talked to the psychiatrist, Dr. Keo Ford, St. Hill. Just wanted to go through some of those, and so that maybe you can say a little something about what we are actually seeing. So hopefully we can bring those up and have Dr. Pierce talk about the slides. Dr. Ford is ready and waiting though, so this is good to know. So if we are getting those slides, it would be wonderful to have Dr. Pierce go through them quickly at this time. We're talking, of course, about the complications of diabetes, and certainly the eyes having it or being impacted by it through this diabetic retinopathy is one of the major concerns. So Dr. Pierce, talk to us about as we look through the slides. See here.
Right. So roughly a year ago, we started in collaboration with the Barbados Diabetes Foundation the Barbados Diabetic Eye Screening Program. And it was really to try and address this problem that you're seeing in clinic every day, where patients are presenting at the end stage of the disease. And an effective screening program can pick up these problems before it reaches that stage, where we can offer treatment and we can say to patients, okay, we have something that we can do for you, and avoid blindness. So just looking at the slide here, diabetic retinopathy is a common complication of diabetes caused by high blood sugar, and it can cause blindness if left undiagnosed and untreated. So I think we can go on to the next slide if you want. And this is just an example of what I was talking about. So on my left, I think it's the left, where you can see it says leakage from blood vessels affecting the back of the eye. That's one of the advanced stages of the disease, one of the most common causes of blindness in the working age population, where you have these yellow deposits in the center of the eye that causes loss of vision and loss of central vision, which is probably the most useful vision at age, really. And then on the other slide, you have these abnormal blood vessels. Oh, sorry, if you go back, yep, the one on the right, where the arrows are pointing. So those blood vessels, you can see they're smaller. They don't look the same as the other blood vessels that are arising from the nerve. And these blood vessels can start to leak, to bleed, and to scar, and cause complications and loss of vision. So next slide. So to minimize the risk of this happening, everyone, type 1, whether you're type 1 or type 2 diabetic, you should have at least an annual screening visit. Someone should have a look at the back of your eyes to see if there's any sign of diabetic eye disease, and then appropriate action can be taken. So next slide. So as we said before, diabetes is increasing chronic diseases, and it is one of the leading causes of blindness in the working age population. And the diabetic eye screening program was created as a response to this, where we have examples in other countries like the UK, where diabetic eye disease was the leading cause of blindness, again in the working age population, a few years ago. And then with the introduction of the screening program, it no longer is. So it's been a huge success, and we have that as an example. So next slide. I think that's it. So diabetic retinopathy screening is the aim of the screening at the Barbados Diabetes Center. Next slide. This is just an example of how it's performed. The patient comes in, we take the visual acuity, We then put some drops in so that the pupils are dilated. And we ask you to have a seat in front of a camera similar to this photo. And then the technician takes the photograph. So it's a painless procedure. It usually takes less than 5 minutes to be done. Next slide.
Because we also have to pause at this point for lotteries, but we will continue to discuss this. We still have to hear from Dr. Ford, the psychiatrist, and so we are going to come right back to your health, your action in just a couple of minutes.
Hon, I know you like your rice and pork, but I wish you would eat more vegetables.
Sweetheart, why do you worry so much about what I eat?
I worry because you have high blood pressure and high cholesterol. The World Health Organization says that people with NCDs are more likely to become severely ill if they get COVID-19.
What?
And now that you're only working 3 days a week, you're spending more time on the sofa, watching TV, drinking soft drinks.
So how is eating like that going to help me? These times are so stressful. Just let me enjoy myself.
Vegetables are high in vitamins, minerals, and fiber to help maintain your weight and control your blood pressure. A healthy diet helps to keep your immune system strong and protect you from diseases.
I know you really care about my health, hon, and I really appreciate it. Look, I'm going to have some vegetables. Can I have a glass of water, please?
Wait, you wash your hands?
Hello?
Hi, Grace Me.
Hey, Cheryl. Girl, I can't talk to you right now. I'm doing my morning exercise.
Babe, since when is your morning exercise so important?
Since the World Health Organization say that people with NCDs are more likely to get real sick if they catch COVID-19.
What?
Yes, you know I'm a diabetic. Plus, I put on a little size. So I got to exercise and use up this little bit of energy that I got to keep my blood sugar under control. Plus, my doctor said that when I exercise, it will help to keep my immune system strong.
Oh, so God forbid, if you ever get COVID, you have a better chance of recovering faster.
Exactly.
Grace, I never told you that I have high blood pressure. I don't even take the medication properly. I looking got to join you in your morning soccer exercise or the line dancing. What do you think?
Yes, and I can send you the same routine that I doing here now, girl. It's real sweet.
Hon, I know you like your rice and pork, but I wish you would eat more vegetables.
Sweetheart, why do you worry so much about what I eat?
I worry because you have high blood pressure and high cholesterol. The World Health Organization says that people with NCDs are more likely to become severely ill if they get COVID-19.
What?
And now that you're only working 3 days a week, you're spending more time on the sofa, watching TV, drinking soft drinks.
So how is eating like that going to help me? These times are so stressful. Just let me enjoy myself.
Vegetables are high in vitamins, minerals, and fiber to help maintain your weight and control your blood pressure. A healthy diet helps to keep your immune system strong and protect you from diseases.
I know you really care about my health, hon, and I really appreciate it. Look, I'm going to have some vegetables. Can I have a glass of water, please?
Wait, you wash your hands?
Hello?
Hi, Grace Me.
Hey, Cheryl. Girl, I can't talk to you right now. I'm doing my morning exercise.
Babe, since when is your morning exercise so important?
Since the World Health Organization say that people with NCDs are more likely to get real sick if they catch.
Welcome back. It's 2 after the hour of 9 o'clock. This is Your Health, Your Action, and we are focusing on diabetes, complications of the disease, and this evening the eyes have it.
Well, we have Dr. K.O. Fordson-Hill, who is a psychiatrist. And Dr. Fordson-Hill, tell us what kind of pressure does the situation that we are discussing here, diabetic blindness, related blindness, create on the person and on the family? What are you all seeing as psychiatrists and psychologists in this country in this regard?
Good night. As you can imagine, losing your sight is a devastating process or occurrence, a traumatic one for any individual. And the thing about diabetes is that there are actually very strong connections between diabetes and mental health issues. So from things as depression, anxiety, and even psychosis. But there's also something called diabetes, which actually occurs in 1 in 4 of type 1 diabetics, 1 in 5 to 6 of the type 2 diabetics, depending on whether you're insulin dependent or you're using tablets. And that is actually a combination of stress, anxiety, as well as depressive symptoms. So the person will not meet the criteria for clinical depression or major depressive episode, but they actually have quite a few distressing symptoms for them. And these are things that actually need to be screened for I may be jumping ahead of you, but these are things that actually need to be screened for at the primary care level. So with the family physicians and general practitioners, they have to have a high index of suspicion with these things. And it's because even just if you look at just it being a chronic illness, diabetes, having to, in some cases, stick yourself every day to check your blood sugar, take medication every day, restrict your eating, as the patient featured earlier was saying, it's hard. It's a hard blow to some persons. And almost everything in our diet in Barbados is high in sugar. So to tell somebody you have to cut back, it actually disrupts their entire life. So we actually get quite a few referrals to persons who are just not managing well with it.
How do you guide those people to take better care of themselves at home?
So what we have to explain to them as well is that the health of your body and your mind go hand in hand. So the same way that the diabetes actually increases your risk of having mental health issues, even having mental health issues actually can do the same thing, which is to increase your risk of diabetes. So even with us at our level in psychiatry, we actually screen for diabetes in most of our patients before we start medication and during their treatment management programs. And we work hand in hand with the other specialists, our other colleagues, the ophthalmologists, the nutritionists, everybody, to make sure that they're doing what they're supposed to do, or at least assist them in doing what they're supposed to do and prevent some of the complications. So one of the things that is actually very important is if we recognize that these patients actually might need referrals to the psychologists, which would be my colleagues who deal with psychotherapy, which is kind of the talk therapy that everybody would associate with mental health, and helping with coping mechanisms and learning how to manage stress and anxious feelings and all those things. And sometimes our role in psychiatry really is to break down a lot of the things that everybody doesn't understand when they go to the other specialists, because we look at the entire patient. So sometimes we have to do a lot of the diabetes education and that sort of thing, but the family physicians are very, very good at doing that.
All right. As you talk about that and all that needs to be considered as you think about all the information that the person has to really deal with all the changes, let's also bring another personal story in so that we can hear from her. Michelle Thompson. She was diagnosed in 2017, let her tell the story. She'll tell you how it went for her. Good evening, Ms. Thompson.
Hi, good evening.
Great to have you joining us this evening on Your Health, Your Action. So I understand that you worked in the restaurant setting before you lost your vision. Talk to us about when you were diagnosed with diabetes and then how this progression happened.
Okay, it started like when I was diagnosed, you go to the doctor, you get regular checks up, and she's saying she found some urine pluses in your urine and stuff, so she suggested that she run some tests. And when she told me that I was diabetic, I told her, I laughed, because I said, I put it in denial. I said, drink some coconut water and blah, blah, blah. Okay. And then it went on that one day at work, I fell twice, because I was a waitress in a hotel. And sometimes you're walking the straight road and you find yourself, it's a narrow path, and you find yourself swaying, like you're losing balance. And then at the advice of my manager, she said, you need to see the doctor, go to the doctor eye specialist and see what is with your eyes. You rub me eye, then another thing, like I was saying this right, dot in my eye. And you're rubbing finger as eyelid that gone into your eye, and you're rubbing, but it's not going anywhere. So I visit one of the local doctors' clinics, and the lady told me, I cannot see behind your eye, but there is a problem. But you need someone to see behind the eye to see what's really going on behind there. And that is when I got the news that I didn't really want to hear.
Wow. So when were you diagnosed with diabetes, and then how long did it take you to find out now that you had these challenges with diabetic retinopathy?
I would say that probably in 2018, but remember before I denied it, I would not accept it. But then
you weren't accepting it before?
No.
Okay.
So then when it really got to that point, then you had to accept it was going down.
So how did you adjust after that?
It was a hard adjustment because you tried medications and stuff, and you get tired of medication because it's 2 tablets 3 times a day and blah blah blah, and you just get tired. I want more tablets, you understand? And then for one reason, a day I was in Belleville at the bus stop going to work, and I blocked at the bus stop. The sugar went down very low. I was picked up by the ambulance. I was in the hospital for a couple hours. That's when I got chastised by the doctors. You need to take the medication. Mm-hmm. Okay, still had the vision then, and then, then after I saw the ophthalmologist for the eye, it was told it was bleeding in the back of the eye, was bleeding, and it was requiring to have surgery. We tried injections, we tried scans, we tried laser treatment, but nothing really worked. And the operation is very expensive. So you tried your best. You pulled money from every corner. You tried your best. So, but yes, still it was not successful. And I came out from work in 2017.
Did you feel like you had time to adjust to what was imminent, losing your vision? Because we take for granted that we could just go to the kitchen and pull this drawer. You have things in a certain order. Did you have time to organize your space so that you could really adjust yourself to this new way of living?
No. I did not. Because you were hoping that the operation would have been successful, but it was not.
And your experience is really an example of what so many other people go through, which is that denial and frustration with having to do things that they didn't have to do before.
Exactly.
And that brings us to the thinking. Dr. Ford St. Hill.
Yeah.
Well, what can you suggest in those cases? Because there are so many people who are caught in that situation.
I was one of those persons.
Yes.
I went to that stream.
Yes.
I went to the stream that I lose a lot of weight, and I was thinking suicidal. God, that's my judgment. That's the truth. I was. And thanks to my pastor and Miss Eiffel, Karen Eiffel, they coach you, they monitor you, and they brought you back. There's a light behind darkness. It's not an easy road to walk. It's not.
Okay.
Dr. Ford St. Hill?
Yes, I'm glad that Michelle actually brought this to light as well, because as I was saying before, it is very, very difficult for some persons, and the majority of persons, to adjust. And this is where education at the beginning, from the time the person is diagnosed with diabetes, is important. Because if they don't, as Michelle was saying, she didn't have time to adjust. So if if we would do a little more in terms of the education before diagnosis, like programs such as this, and then at the GP or family physician level, a lot of education about the complications and of diabetes. But sometimes, even as Pedro was saying, there are instances where persons might not feel like they've gotten, the best feeling after they were diagnosed with diabetes, and may not feel like they got the best treatment from their provider. And it's okay it has to be a two-way street. You have to communicate with your provider and say to them, well, because we have this mentality, a lot of patients have this paternal relationship with their providers, where it's okay, the doctor said it, so I don't ask any questions. But it's important for you to ask as many questions as possible and to do as much reading as you can on your own. We have access to information at our fingertips, because if a lot of persons would have known that this could be the result, it may actually change their behavior in the beginning. And sometimes it takes speaking to your patient over and over and over again, because for that news, they may not take in everything. The next time they come back to you, you have to go over it again, because it is hard. It's not easy.
I wonder if either Pedro or Michelle have any questions that they want to pose to either of the specialists that we have with us this evening.
Oh, okay. To Dr. Pierce. How should I put it? I know it's a hard thing to say. Can you guarantee that you would get your vision back if the operation is successful? What is the guarantee? Was it 50-50 or is it 75-25? What is the percentage of retaining your vision when it's that bad in diabetes?
So, unfortunately, I would never be able to guarantee that you'd be able to completely get your vision back to what it was before. Remember, I said that diabetes, there are a lot of processes going on. So even if the operation is successful in terms of flattening the back of the eye, so it's in position, and getting rid of the blood that's also inside of the eye, the blood supply to the back of the eye is likely affected. And if the blood supply is being affected by diabetes, then unfortunately you're not going to be able to reverse that. So it's very difficult to actually say what the final outcome is going to be after any intervention. All we can say is that the earlier that we catch it, and the earlier that we use whatever treatment we have available, then the better the outcome is likely to be.
Okay.
Sorry, go ahead, Michelle.
Okay. So right now, at present, right, wouldn't it be better if, for instance, like we start to try to educate children from small and come forward about what is diabetes?
Yes,
and
for sure.
Try to find out their family trees and different stuff. Because if you don't start early, don't wait to get make a woman. You understand? Start young, so your children know what to do and what not to do.
You've said the right thing there, Michelle. You've said the right thing, and we plan to address the children, but that's definitely a part of it. In terms of trying to change the way we behave regarding that. Let's find out also if Mr. Belgrave had any questions that he wanted to ask of the specialist. Mr. Belgrave?
Okay. In terms of my question to the specialist would be, if you say you're the main vessels that bring the blood to the eyes, is there, as a diabetic, is there anything that can happen that can reverse that, or how can we stop that from being damaged? Except I don't know, in terms of being diabetic. The optic nerve, the main nerve in the eye, because that is what I was told after I went overseas for treatment. My retinas were placed here in Barbados. The stores did a good job, but then when I went, I still could not see. When I went overseas, they told me that the optic nerves in the eyes are bad, which is the main vessel. They told me that bring blood to the eyes.
Okay.
In terms of the steroids that were put on that what they're telling me, steroids that were put in the eyes before, probably those that could have damaged the retina from both, could have damaged the optic nerve from both eyes.
Dr. Pierce, can you respond?
So steroids can cause the pressure to go up in the eye. And if you have sustained elevation in the pressure in the eye, it damages the nerve, the optic nerve, and it can cause loss of vision. Now, the steroids that we used to use is slightly different from the steroid that we use now. So the one that we use now, there tends to be less of this increase in pressure. And if it does go up, we can usually treat it with drops in most cases to reduce the pressure and control it. But unfortunately, once the nerve has been damaged due to high pressure, then you can't reverse those changes.
Okay, let's go to a question via WhatsApp. It says, on becoming blind from diabetes, what is the time frame to have the surgery?
So that depends on what's it. So if you've had laser in the past and then you had an episode of bleeding in the eye, you have a bit more time to play with to have surgery or further laser. If you've never had any treatment in the eye and then there's bleeding, you need to either operate or do laser surgery if possible sooner rather than later. But in all cases, you're trying to operate as soon as possible for the best outcome. But I realize, unfortunately, the eye unit at QEH is under quite a lot of stress. There are quite a lot of long waiting times as a result of COVID for one, and then there's quite a lot of backlog of patients who are waiting to be seen. So that has increased the waiting time for surgery for quite a few patients, unfortunately.
Hearing here a couple of things, and that one of the things is you really have to, when you are diagnosed with diabetes, take it seriously and try and get it under control as quickly as possible to avoid the progression wherever possible. And each case has to be dealt with based on the person as an individual situation. There's no broad treatment. But we have another WhatsApp question as well, so let's share that now. What are good blood sugar readings and what are bad blood sugar readings?
So again, this is individualized from person to person, but what we're looking at mainly is the HbA1c, which gives an average of the blood sugar reading over roughly around 3 months. So ideally, what you're aiming for is a blood sugar reading probably less than 6.5. Wouldn't quote me because this changes all the time, but I would say around 6.5 or less. But obviously, if you're starting off from an HbA1c above 10 and you're now at 7, that's a significant improvement for you. So it has to be individualized with the patient as well. So I would suggest that you would talk to your primary care doctor or your diabetes specialist in that case.
That HbA1c is something that many people do not necessarily get, and they must remember that they need to ask for it. Again, in many instances, it comes at a cost as well. So guide people as to exactly what is the best way, and let's talk to those who are less advantaged in the first instance when it comes to dealing with something like this, because it's an important tool in trying to determine what is happening to a person.
Yeah, absolutely. If it's available, it's probably the best measure that you can have to determine how well your control is over a long period of time. The other option is fasting blood sugar, That also gives you a good immediate indication of how well your control is at the time that you take the blood test. Again, you're probably looking for fasting blood sugar, probably less than 6, I would say. Again, don't quote me on that exact number, because that does change and it varies person to person in terms of what you're eating.
Available to members of the public who want to pursue more information and perhaps have been diagnosed and want to know where we can go to get the assistance that is necessary, other than just going to your private doctor, because many of these people may want to go to the polyclinic. Where do they go?
So absolutely, the public polyclinic is a good option if you for the control of your diabetes as well. And there is the option, of course, to refer to the eye unit if at the QEH, if there are significant problems that are found that need treatment, or if you need to have closer monitoring of your diabetic eye disease.
So again, I don't know what it is about the medication, but Dr. Ford, I want you to also reiterate the importance of acceptance, because that was another thing that Michelle clearly and generously shared with us, that she refused to accept that, she's diabetic. And if you don't accept that, the diagnosis, well then we can't really get the help that is needed.
This is correct. And if we start from now, I love this program because this is a very good initiative. At every checkup that you get, encourage everyone to actually get annual checkups where we as physicians can speak about your lifestyle changes in terms of your nutrition. I don't like the word diet, but your nutrition as well as your exercise. And by exercise, I just mean movement, daily, and in terms of changing our habits. Then, because the fear with everyone is, I don't want to stick myself every day. The fear of needles and sticks and blood is actually the one of the most common phobias that there is. And generally, persons just don't like pain. Right. So everybody thinks about diabetes and thinks about insulin, as well as getting their blood sugar checked. And some of the oral medications for diabetes, some of the more common ones, can actually cause a few, I would say, uncomfortable effects, and not necessarily adverse, in terms of you having an upset stomach and that sort of thing. And persons are actually, they may take the tablets, and then if they're not informed that these things can happen, then they're less likely to be compliant with the treatment. So it's very important that at each visit that some form of education about surrounding the illness is planned, in terms of talking about the complications, talking about the medication, making sure that the patient is informed about the adverse effects, because they're more likely to continue taking the medication if they're already in their mind informed that certain things can actually happen. Otherwise, wait, this doctor give me this medication, that agree with me while taking this no more.
And I'm glad you said that, because looking back at one of our guests last week who shared his journey, he's an amputee, Giles Bend, and he said that one of the medications would cause him to be impacted by diarrhea. And I'm thinking this is something as well that your doctor should say to you, especially understanding your lifestyle and what it is you have to do. All of that has to happen so the adjustment is real and you can live as normally as possible.
We have another question.
Yes.
Can you explain the risk for someone who is pre-diabetic? Dr. Pierce?
So is this the risk of the...
I believe you tie that to the whole question of the diabetic retinopathy.
So we don't actually start screening for diabetic retinopathy in a patient who is pre-diabetic. Again, you could, if you wanted to, have a eye check to make sure that there are any changes that are developing. But if you've not had a diagnosis of diabetes, then it's very, very unlikely that you're going to have diabetic retinopathy changes present. And again, in most cases, it takes several years from the initial diagnosis of diabetes before you begin to see eye changes happening. So in the pre-diabetic stage, you're very unlikely to have any eye disease, diabetic eye disease at least.
A number of people who sometimes have diabetes but haven't gone to the doctor, haven't checked it out, and by the time they get to you, they have more of a problem than they thought they did.
Yeah, that's absolutely true. And sometimes we can make the diagnosis of diabetes when they come for an eye check and you have a look and you see these changes that are characteristic for diabetic retinopathy. And then they get referred to their doctor who makes a diagnosis, confirms a diagnosis of diabetes.
I think this information has been incredibly helpful. I think we have a question. Michelle Thompson has been sharing her personal story. Michelle, you have a question?
Okay. Highlight on this also. I have also lost a toe to diabetes.
Okay.
Yes. So it is like, and all the doctors telling me, don't come to lose another. Try your hard to keep your sugars under control and your pressure. So I am trying very hard not to go back. This happened in 2017 also. 2016 I lose the toe. So far so good. No more.
Fantastic.
So, so I'm just trying to tell you, just be aware of the situation. Follow the doctor's guidelines. If you're not sure, as you said, ask questions. I lost my sister to diabetes also, and she was a double amputee. And, so I have personal experiences in knowing what it's all about. So I try very hard to, just to be as careful as I can be. And should go ahead and continue to educate the children from like nursery and come up so they will know what it is. And to the public, general public, please be aware. Don't spend the money on the clothes and the hair, doing the nails and the shoes and the men and blah, blah, blah. Try.
Well said. Well said.
Go and see the doctor at least once a year with your eyes. If there's something wrong, if you're looking and you're seeing a right spot in your eye, find out what it is. Be careful of the glare from the cell phones and the laptops and the computers. There's a lot of radiation and stuff. So my advice to everybody, just heed to the doctor's advice and have a wonderful day. And thank you very much for having me.
Thank you.
Thank you so much. Michelle Thompson, thank you also to Pedro Belgrave. Thank you to our health professionals, Dr. Charles Pierce, ophthalmologist, and of course, Dr. Keo Ford, St. Hill psychiatrist, and to our partners, David. Such invaluable information as usual.
Well, quite an end to tonight's program. And I just want to remind those of you who might have joined us late that you can also go back to YouTube and see not only this particular episode, but the previous episodes of Your Health, Your Action. Just put in a search for Your Health, Your Action, and it will be all there for you.
Yes.
Thank you.
Looking forward to spending next Wednesday evening with you, at least for 1 hour. We'll pay special attention to women's health. So join us then. You be safe and have a good evening.